All right, you're welcome to this opportunity, wonderful opportunity to give these brief highlights of our forthcoming lectures. So we're going to be looking at highlights on renal allografts and rejection. My name is Godwin Agada Negedu, and I'm your regular anchor. So this discussion, the whole of it, will cover evaluation of transplant kidney, both on the donor side and on the recipient side, the complications of renal allografts and rejections. But before then, please always remember to subscribe to this channel for more quality lectures, share our videos, further reach, and please like, put on your notifications so that you get all the free lectures we post here. More information about our paid classes because we train um, medics, radiographers, doctors, sonographers, nurses, and allied health on the use of ultrasound for that purpose. So you may want to reach us at sonoeyesdiagnostics@gmail.com, or you can WhatsApp at +234 9019 144175, or you visit sonoeyes.business.site. There are quizzes to be attempted. Please always attempt the quiz. So welcome back. Ultrasound plays important role in the initial and the long-term follow-up of renal transplants. Allograft refers to any tissue transplant from one human to another human. Therefore, a transplanted kidney is a renal allograft, and usually it's abbreviated as TX. Now let's look at surgical technique that's usually is used to achieve this before we go into the ultrasound discussion. So renal allograft usually is placed in the iliac fossa between the peritoneum and the iliacus muscle. This retroperitoneal or extra peritoneal, this is actually a retroperitoneal or extraperitoneal in child. In child, the allograft may be placed intra. If it is too big for the usual extraperitoneal location, a right donor is usually turned over so that renal pelvis and ureter are usually positioned anteriorly to permit easy access if later intervention is required, and placed in the recipient's left iliac fossa. Similarly, a left donor kidney is placed in the recipient right iliac fossa. The allograft ureter is passed through an oblique tunnel in the muscular layer of the bladder, forming a non-refluxing uterovesical junction. Now, in the main video soon to come, all the images, animations will be made available for you to see. This is just an highlight. The transplanted renal artery may be attached in one or three ways. In one of three ways. There is the end to side. The end of the allograft artery is attached to the side of the external iliac artery. Now, this is the most preferred method because of lower incidence of post-operative stenosis. That is end to side. Then there is the end to end. The end to end of the allograft artery is attached to the end of the internal iliac artery. In other words, the native internal iliac artery is severed completely, and the other portion is is occluded, then is attached to the allograft renal artery to achieve this. There is the Carrel pouch. In this case, cadaver kidneys are commonly removed with a portion of the aorta. The aorta is sutured end to side to the external iliac artery. Multiple renal transplant artery requires additional anastomosis. The transplanted renal vein is usually connected to end to side to iliac to the external iliac vein. The native kidney in all cases are left in place unless they are associated with complications like um, infection, post-dialysis acquired cysts with risk of developing neoplasm. So that's the condition where you remove the native kidney. Otherwise, you just leave it there redundantly. Now let's look at the renal allograft scanning protocol. Renal allograft is usually located superficially. Therefore, you will need a probe of 5 to 7 megahertz linear or curvilinear array transducer, which will be used to produce a good near field image or a broad field of view. A baseline scan is performed within the first 24 to 48 hours following surgery. This provides a frame of reference against which all the future scan will be compared. A second scan is performed 1 to 2 weeks post transplant, and a third scan at about 3 months. The scan of the renal allografts are usually done with a full bladder, which helps to displace overlying bowels from the transplant. The transplant kidney is scanned both sagittal and transversely. The maximum length, the width, and the AP measurement are taken, and the renal volume is calculated. An increase in size in this transplanted kidney is best appreciated through volume measurements, not just area, which is an important feature of allograft pathology. Echogenicity of the renal cortex, the renal medulla, and renal sinus is evaluated, and if it is followed up, and if it is a follow-up scan, we compare to the baseline um, the previous scan. The perirenal area is scanned for possible complications like masses, like hematoma, like fluid collection, lymphadenopathy, and so on. Slight dilatation of the renal pelvis is common and normal. However, dilatation of the calyces is a reliable sign of obstruction. If hydronephrosis is present, the bladder should be emptied and re-examined to see if dilatation is secondary to bladder distension. Doppler study is essential for evaluation of the patency of allograft artery and vein. Color Doppler, spectral Doppler of upper, mid, and lower pole intrarenal arteries are obtained, and the RI is calculated. The power Doppler provides evaluation of vascular perfusion of the allograft and is used to detect focal flow disturbance. On ultrasound, a transplanted kidney looks like a normal kidney with the following variations. Echogenicity of the cortex is equal or slightly greater than the medullary echogenicity. Absence of corticomedullary differentiation is often a normal thing in normal transplant kidney. Echogenicity of the cortex and medulla is uniform throughout the kidney. Areas of focal increase or decrease suggest pathology. The renal size, here the volume of normal renal allograft may increase in the first 2 to 3 weeks after surgery by as much as 20%, which is normal because after surgery there's certain edema occurrences and stuff. Normal kidney in transverse scan is elliptical in shape with width greater than AP dimension. Rounding of the kidney with AP dimension equal to the transverse dimension is a sign of diffuse renal swelling or enlargement. Mild pelviectasis is common and normal. However, hydronephrosis may be due to obstruction or edema of the uterovesical anastomosis site. Now, these images, which you see in the complete video, shows the ultrasound appearance of renal allograft in the grayscale. Then look at the color and power Doppler um, appearance of renal allograft. And complications can occur in renal allograft, and there can be several of many things. But in the larger video, we're going to be looking at the issues one after the other, and we'll deal with the details. But in this feature presentation, the highlights of that video, I want you to have an idea and keep a date with us. When we post the full video, you will learn something new. So I'm sure you find this information very valuable, both in this feature presentation and in the full video that is to come. I want you to please share, like, and subscribe. Let's have a wider reach so that you can have more quality videos like this. Until next time I come your way again, keep learning ultrasound.